I'm Roger Adelman, and I want to use this medium today to communicate some information that I think is going to be useful to all of us. I'm both a researcher, a PhD biomedical engineer, and I've had enough of medical school to know pretty much all of the terms in anatomical sense. I'm also a patient that could benefit from what I'm about to present, and if not for me, then for many patients like me who could benefit from significantly from better practice or a better linking of what we can do with imaging and what we can reproduce in a meaningful way for surgeries, and as actually the missing link that exists today between what we practice in robotic surgery and the information that we take with CTs, MRIs, and other three-dimensional imaging techniques. It's my experience, which is limited and why I'm going to you, that while we take information at a fantastically detailed and accurate level with CTs that now are 6/10 millimeter scan thicknesses and 3/10 in-plane resolution, that we, in presenting that same information for the critical clinical surgeries, we wind up throwing away a lot of that information. And for sure, we toss away the numerical representation of that information that is at the heart of real robotic surgery. But we can back up from that a little bit first. What I'm going to present is what I've been able to do with software that's available. A Belgian company, Materialize, has since at least the 90s and probably the 80s recognized that CT images could be reduced in a meaningful way to their equivalent that engineers and aerospace, whether they're in aerospace or military or automotive, have used as common basis for creating three-dimensional models. And the three-dimensional model then becomes representative of reality in a way that it can be treated with enough arithmetic to determine the stresses that are involved, the way things will stretch, the way things will be placed, the way that we would plan to make an airplane if we had to. Let me make a quick analogy. If I want to have an airplane built, I employ a group of specialists to design, to test, to reduce their ideas through correct modeling and correct mathematical representation into things that can be built. And then we use those models today to create the numerical engines that drive the lathes and the milling machines and the jig borers and the grinders and all of the things that are required to create the model. Ultimately, there's no reason why that same practice shouldn't be done in the operating theater. Today what we do, and this is why I'm going directly to you, is we take data and we produce images that then we use to provide, that are then used by the surgeons, by the radiologists, in presentations that are not a lot different than the way that our fathers and our grandfathers looked at radiography and tomographs. Some 3D imaging is done, but it's done for artful practice, when in fact the 3D imaging lies at the basis of creating models that are accurate enough to determine all of the tugs and pulls that will be placed on the tissues when surgery is conducted. And models that will allow templates to be made to fixed points that are recognizable so that a surgeon, for every patient, every individual patient, can have a set of individual templates exactly tailored to that person's needs. In my case, I want to talk about pedicle screws, and we'll get to that in just a minute. But before we do, let me show you some things. This is a real this is real bone, a real representation, a skeleton from life that's used typically for a surgeon to show where the pedicles are, or the spines, or the articulations that occur in normal spinal movement. They're used as show and tell pieces. Why shouldn't we have the ability to build and represent and show and tell in plastic a model that represents the same reality, but is derived from the very CTs and MRIs that are now represented as tomographs? I had this one built. This is incomplete. This is my own, essentially T12, T11, T10. And it goes with the rest of a structure that's partially broken at this point. At one point, this was all together. That shows what is reality inside of me, right down to the representation of the cortical and trabecular bone, accurate to better than a millimeter. This model was built, the full model, I had built on purpose because using an inexpensive process that was rapid, not particularly durable, but rapid and cheap. The machine that made this cost $65,000. It took 6.5 hours to build this model. And the total cost of the model is about $200. It's fragile, but it's accurate. And you can see my own personal interest in this, in that the remainder of the pedicle screws and rods that are in me are nicely represented. And without ever having any knowledge of the size of these things, I can tell you to the fraction of a millimeter, the thread pitch, the size of the rods, all of that that's necessary to really reconstruct, to be used in a meaningful way in reconstructive surgery. The surgeries that are done and were done on me should have represented a practice not unlike that airplane that I was talking about, where we went through a planning procedure based on real information and real representation of accurate modeling, and then a planning that would be used to guide the surgery that's necessary to be performed, so that we wouldn't be guessing, we wouldn't be surprised at the in vivo presentation of what we'd been able to see and even cut in vitro. It's accurate. In my case, I'm fused now I'm fused from S1 through L4, and the pedicle screws to a greater or lesser extent are doing some work. There's also a large incidence of fairly obnoxious bony structure across the transverse processes that was more of an artifact of the surgery than a plan, because On the right, you can see almost a total shell. On the left, an incomplete fusion. Is that as good as it could be? No. I've been told that we can't predict where bone will go. That's incorrect. We can predict things. We have been able to since Wolff's Law came about in, 1867? If we knew where the stresses on the bones were. All of that can be done. In my particular case, there was a malfusion. There was a complicated first surgery with not a herniated disc, but a disc that shattered. And it sent debris up the spinal canal that was impinging on the spinal cord. The neurosurgeon involved in the process, deftly picked out bone to preserve neural structure, and he did a good job. But again, because of the surprise at surgery of the extent of what had happened, he used the best he could at the time, a plastic ligament, to add structural integrity to the bony structure that he had to destroy in order to create, in order to preserve good neural structure and to impart flaccidity back to the spinal cord. However, that plastic ligament broke, and subsequently there was a surgery where a fusion was told to me, a lateral fusion was to be performed with my own donated iliac crest spicules to create the structural integrity. In fact, it was performed, and no provision was made to hold the bony structure in place. And so what happened was a fusion between S1 and L5 occurred, a malfusion that cast off the base of the vertebral column in an anterior position and laterally to create a spine that never had scoliosis prior to that. That building of a new base for a spine that was otherwise, for a vertebral column that was otherwise textbook, caused a large amount of shear stress at L5, L4. And because of that, L5, L4 failed. So the next reasoning, taken only from tomography, was that there was degeneration of the vertebral column, disc degeneration, as well as there was some stenotic things. But primarily disc degeneration. No history of osteoarthritis, no nothing. But on the tomographs, there was obviously a shearing of the disc. So the surgery was conducted again. And then L4 was fused to L5, casting it off in the same direction and making this even further displaced from L3, L4. And what happened next? L3, L4 failed, and so on, until the sixth surgery came about, and it was determined that I had disc degeneration, all on the basis of CTs, MRIs, and never once a three-dimensional model. And so the fix for that was pedicle screws and rods. Pedicle screws and rods that continued to build in angular fashion, anteriorly and laterally, an increasing difference between the remainder of the vertebral column, which by that time was already up to the floating ribs and into the rib cage. Today, that's the cast of this model. It was after that surgery several years after that surgery, when spondylolysis continued and the pain associated with it continued, that I decided to look at what was available. And what I found was the Materialize product Mimics, which, as I said, since the late 80s or early 90s, has served to take CT and MRI data and convert it into the same kinds of file structures that engineers and scientists and designers of spacecraft use. Much more efficient storage and much more versatile representation, so that we can present in 3 dimensions in any direction, any slice, any degree of fineness of slice. The representation that's acquired by that imaging. And because it's numerical, even in my case, where it's screwed up, the screws, literally, the screws will stay in place. And I can build templates, stainless steel templates, that are derived as to where to make the vertebral, is that a problem? The vertebral osteotomies that are essentially done by eyeball. And we can precisely determine what bone has to be removed from where in order to restore as close to normal structural curvature as there is. I have what the orthopedists would call flat back. I also have scoliosis. I also have spondylolysis. All of which, at least in my mind, could be corrected if surgeries were planned and coordinated and directed in the same way that we build spacecraft or airplanes or even the ball joints in your car. It doesn't detract from the necessity for surgical skills and all of the challenges of the surgical theater, the reality of living tissue, the reality of vascular damage, neural damage, all of the things the surgeon has to consider. But there are things that the surgeon doesn't have to know. The surgeon only has to follow the templates and the directions the same way that someone who is tuning an Indianapolis car, the mechanic that builds it, the artisan that welds it, is working to instructions that are reduced to numerical values. And that's the whole essence of trying to get your interest and your input so that I'm not talking into the wind. There's a lot I don't know. Sure, I've done the dissections. I know the parts. I've not done a live surgery. I'd be put in jail if I tried. So there's a cooperative need for all of us to advance some science that we can do in a meaningful and expeditious manner, and stuff that doesn't cost an arm and a leg. It's not an argument. This is cheap stuff because we use it on cheap parts. And that's what I'm asking you to let me help you consider. Let me show you. Give me the time to work with me. And these people that have helped me make this wonderful video that I hope hasn't taken too much of your time, that all of our time won't have been in vain, and that we can advance something that can, if it's too late to help me, that's one thing. But it's not too late to help the next person that presents like me. And that's something we have to do. I thank you for your time, and I hope to meet with you soon.